At this point, I'd like to invite Carlo to give the next presentation, and he will tell us about how to do dual Stim to optimize the number of oocytes and the time to pregnancy in low prognosis patients. Carlo, please.
So I finished. Thank you. So the last sacrifice before lunch. So now we talk about dual Stim. I don't know how much you have this kind of, if you started with this kind of experience, but I think it's a good opportunity to try to, I want to take the time because I don't want to run risk to take too much time. So I will bet everything. So I would like to talk. This is my disclosure, obviously. But before, we have new football questions. No, I'm kidding. In which patient profile would you consider adding LH in a dual Stim protocol? In women above 35 years, poor responders, women regardless of age, and women undergoing PGTA for advanced maternal age. All the answers are okay. In your opinion, is the option. So your opinion is important. So I think we can check what happened. All the above, okay. And so this is good option. So I'm curious to know what you think at the end of the talk. So why should we consider accumulating oocyte or accumulating embryos? And but the first question is why we can hypothesize that this is possible. And so I would like to introduce the concept of follicular waves and how we can search follicular waves during our stimulation protocols and the way we can do it. So let's start from the first point. Why should we hypothesize? This is something that we have to have clear in our mind that at any given moment, there are follicles in the ovary at different stages of maturation. It seems to be obvious, but this is the starting point we have to keep in mind. This is a representation, histological representation of different follicles at a different stage, from primordial up to dominant graft follicles. And how follicular genesis works. So there are two theories. One theory is that we have a continuous movement of follicles, this random movement, independent follicles movement. And from this pool of continuously moving follicles, there is the selection of dominant ovulatory ones by chance. And the second theory is the concept that I found very intriguing, that we have follicular waves moving throughout follicular genesis. So follicles move as packages, and this not is in a random continuous, but specific waves move in a very continuous way. So what I would like to show you, this pyramid is very important. Here we have from primordial to primary, secondary, early antral, different stages of antral follicles. And so when you have the so-called initiation, what is initiation? It's a moment where a package of primordial follicle move to the stage of primary follicle. This initiation is not regulated by gonotrophins. So we remember altogether that primordial follicles are gonotrophin independent follicles. So we don't know the reason why packages of primordial follicles, waves of primordial follicles, have this process called initiation. One thing is clear, that when a given number of primordial follicles became primary follicles, in 90, probably 120 days, from these primary follicles, we will have a given number of antral follicles, and from these antral follicles, stage 5 antral follicles, we will have the dominant one. So it takes 90, 100 days for having primary follicles becoming antral preovulatory follicles. And at any given step, there is lost. There is a percentage of follicles going to atresia. So we move, for instance, we move from 1,000 follicles, a package of a wave of 1,000 primordial follicles becoming primary, and step by step, there is a reduction in the number. That's the reason why the antral follicle count we perform at the beginning of the menstruation is representative of the ovarian reserve, because all the follicle population are in equilibrium among them. So the more is the number of primary, the more is in proportion the number of secondary. So when we have antral class 5 follicles, meaning between 2 and 9 millimeters here, the more is the number of antral follicles during menstruation, the more is the number of primary follicles in the ovary. But these primary follicles started 90 days before. And once they start, probably they move in waves. So, but let's go deeper inside. I need your attention because this is something that we have to imagine all together. If we have a look to the menstrual cycle, classical menstrual cycle, ovarian cycle, we have higher FSH dose during the menstruation. Then the FSH goes a little bit down. And then we have a peak at the moment of the LH peak and again down. And then it rises again in the interface between luteal phase and new menstruation. What does it mean? That we have fluctuation of FSH every 14 days. More pronounced at the moment of LH peak, less pronounced at the beginning of menstruation, but LH is fluctuating. Every 14 days, we have fluctuation. I need your imagination, because if we consider that all the follicle population are in the ovary at the same moment, at any fluctuation of FSH, FSH is working on different waves in different classes of follicles. I like to imagine like Roman legion. These are the way Roman legion move. The leader, and then the other section, the other legions. So when we have an FSH peak during a given LH peak during a menstrual cycle, this FSH peak is probably working on all the follicles growing in the ovary in that given moment. Obviously, the most important effect is the selection and rupture of dominant follicle. But at the same time, this FSH is working on all follicles, moving probably progressive movement, steps on. So from this primary, in 90 days, with this fluctuation, you will have new cohort of antral class 5 follicles. So you can imagine this. And so if I give FSH in this moment, I'm moving follicles, dominant, antral, early antral, all follicles together. This is very important because let me tell you, this is what I was talking about this morning. Let me tell you what happened, for instance, in a young patient. In a young patient, we have in the early follicular phase, perfectly aligned follicles deriving from 90 days selection in the previous months. So you have a FSH increase, you have a selection of codominant follicle, dominant follicle. When dominant follicle reach a given size, you have LH and FSH peak. And again, you have rupture, ovulation, corpus luteum. At this moment, the FSH peak is making follicles growing. These are probably class 5 follicles for the next cycle. But in this young patient, we have a good level of anti-Mullerian hormone. So this progressive selection of follicles for the new follicular phase is very harmonic and progressive. And we have a very good synchronicity. So at the beginning of the cycle, you will have perfectly aligned follicles. What happens when you have a patient which is elderly patient, low ovarian reserve? You have ovulation, but you can see that following the corpus luteum structure is there, you see that the follicles are less, the anti-Mullerian hormone is lower, and you have asynchronicity among follicles. And so you can see that you have dominant follicles, not at the moment of menstruation, but before menstruation. And so they are not aligned. And that's the reason why we were talking about the possibility of synchronizing this follicle during the luteal phase or during the early stages of a new follicular phase. This is very important, but what I need, what I hope I was able to make you imagining is this dynamic activity of FSH and LH that in a different, despite the peak is at the same moment, the action is different and distributed on different follicles. This is something that I would like to, I don't want to consider the impact of generate agonist long protocol and letrozole at this case because it's too much information. What I want to tell you now is that if we consider what we discovered in the last years, we discovered that you have synchronous waves of small antral follicles recruited during the ovarian cycle. Because if you have the image I presented clear in mind, anytime there is an FSH movement, you have an advancement of small cores of follicular waves. And this is very important because what happened is that there are two possibilities. One possibility is that from a given wave of follicle, you have a phenomenon which is called deviation, meaning that one follicle became dominant and this follicle reached maturity and gives ovulation. But it's also possible that the follicular wave doesn't give deviation, so no follicle became dominant. So the follicles of that way will go to atresia again without having a dominating follicles. And this is what happens during the luteal phase. Because during the luteal phase, what happened, this is a representation of waves. So you have the FSH and LH peak, so you can have ovulation, but you are moving also follicles here that are preparing for the next cycle. But what is clear is that if we consider the follicular wave during the follicular phase, the progesterone is very low. Given that progesterone is very low, you can have deviation and you can have ovulation. When the follicular wave is sustained in the luteal phase, the progesterone is very high. And when progesterone is high, the LH is suppressed. And so you have the follicular wave, but you don't have a deviation and you don't have the selection of dominant follicle. So the presence of progesterone suppressing LH is very important for having the wave moving, but not the selection of dominant follicle, because the movement of this luteal phase wave is very important for having new antral follicles in the next menstruation. And it has been proven that with the FSH and the LH movement, you can have even 3 follicular waves moving in the same cycle. One is functional to ovulation, the one that occurs when progesterone is low. So you can have deviation and selection of dominant follicle. The other waves are not for dominant follicle, they are for preparing new course of lesions for the next cycles. So that's the reason why we thought to intercept these waves and stimulating the patient many times in the same ovarian cycles. This is to demonstrate that we can have even 3 follicular waves in the same menstrual cycle. I invite you to read these papers that, in my opinion, are very exhaustive in this. And so you can, at any moment, you can intercept with FSH and LH activity these waves and making follicle growing. So I come back to the Poseidon group, and I focus on group 3 and 4. In group 3 and 4, the problem is that the ovarian reserve is low. So you have 300-400 follicles probably. So you cannot create new follicles. You can have the best gonadotrophin, you can have the highest dose of gonadotrophins, but if you start to stimulate when follicles are between 4 and 9 millimeters, you can have maximum the number of mature follicles corresponding to the initial antral follicle count, not more. So if you have 300 follicles, you can have maximum 3 oocytes. So the only way we can have an optimal number of oocytes in these patients is probably accumulating, stimulating more times and accumulating follicles. This is just to give an idea of what happens. So if you consider a patient above 35 years of age, year by year, you have a dramatic decrease in the rate of a euploidy. So you have in a patient 42, 41, 42 years of age, less than 10% of blastocysts are euploid. And you have progressive decrease in euploidy. And you have at the same time, for counteracting this decrease in the euploidy rate, you need more eggs. But you need more eggs in the moment where you have less eggs in the ovary, less follicles. So you need more follicles, more eggs for counteracting aneuploidies, but you don't have follicles because the patient is aging. So I think that, for instance, you need minimum 10 oocytes for having 1 euploid blastocyst when the patient is 40, and probably minimum 20 oocytes for counteracting aneuploidies when a patient is 42. So you need 20 eggs. And so the only way to have it is accumulating. That's the reason why we can consider the hypothesis of the art calculator, because you can, during counseling, you can explain, you can dialogue with the patient and say, you are 40, for instance, you are 36, and the vast majority of your embryos have chromosomal abnormalities, so only 20% of your embryo will be competent. So for having an adequate probability to have at least 1 euploid embryo, we need 15, 12, 20, it depends on case by case. You can calculate with the patient. And if the ovarian reserve is not consistent with this, you can propose to accumulate. And so how you can accumulate? This is the famous Shanghai protocol. You remember this? This is the first attempt, starting with the clomiphene, adding ACMG, using letrozole in the first days for trying to have a very cost-effective approach, agonist triggering, oocyte retrieval, new stimulation after 3 days following oocyte retrieval with HMG. And you can see that medroxyprogesterone acetate is given here, and ibuprofen is given at this stage. This is the Shanghai protocol. It's cost-effective, but it was conceived for very low ovarian reserve, bad prognosis women, because it's inspired to the principle of cost-effective, not using expensive drugs and trying to maximize induced stimulation the ovarian response. Please note that ibuprofen is given for preventing ovulation, because ovulation is an inflammatory process. So giving high doses of anti-inflammatory drug should reduce the possibility of having premature ovulation. These are patients with 1-2 follicles, very, very bad responders. And the medroxyprogesterone acetate is given not for preventing LH surge, is given for not making patient menstruating during second stimulation. This was the initial rationale of this. This protocol has been adopted, but a very nice idea, but it was dedicated to patients with a very low prognosis, and probably the results were intriguing by cost-effective point of view, not in terms of efficacy, in terms of efficiency. Basically, moving from this idea, coordinated by the group of Filippo Baldi, we developed an adaptation of Shanghai Protocol, which is called Stim. Is for patients still having an apparently acceptable ovarian reserve. And so you start regular stimulation with the gonadotropin antagonist. You can trigger with agonist, ovum pickup, and then you have 5 days stop. On the day 5, after egg collection, you start with the second round of stimulation until maturity of the follicles, and you perform a second pickup. So you have 2 stimulation in the same cycle, ovarian cycle. Egg collection, wait for 5 days, and you start again. So which are the results? This is the initial study performed coordinated by Filippo Baldi. And you can see one thing. These are the results, first stimulation and second stimulation. Please note the incredible inter-individual, intra-individual variability. Patient that had 3 eggs and 1 blastocyst for the first stimulation had 5 or even more eggs in the second. And it was all observed the opposite. But you can see that there is an incredible variability in the same patient throughout the 2 stimulation. That means that probably the value of anti-Mullerian hormone is relative, because the same patient can give more or less eggs in 2 different moments of the same ovarian cycle. What is important is the antral compensatory movement, the antral follicle count in different moments of ovarian cycle. But what is very important from this study is that if you have looked to blastocyst quality and to the rate of euploidy, there is no difference between follicular phase and second stimulation. This is very important. So the concept, we learned this also from oncologic patients and random start. The concept is that the relevance of stimulating in follicular phase is for the synchronization with the endometrium in nature. But you can stimulate the patient at any stage of ovarian cycle. It doesn't modify quality of oocyte, quality of embryos, and rate of euploidy. At any given stage of ovarian cycle, you can stimulate. The quality of the eggs is the same. This is the first crucial point. The second crucial point is it has been observed in many trials, and now it's clear that if you do back-to-back stimulation, because one could say, I stimulate now, and a second stimulation in a follicular phase of the next cycle or in 2 months. But if you stimulate soon after follicular phase, you do back-to-back, the second stimulation gives more eggs. Vast majority, if you see both the number of oocytes and the chance of having a blastocyst, euploid blastocyst in general, the vast majority of a blastocyst and oocyte derives from the second phase. I don't like to call it the luteal phase because, in my opinion, is a iatrogenic new follicular phase. But let's call luteal phase. You can see that the vast majority of a euploid blastocyst derives from the second because you have more eggs. We can discuss about why, but if you do follicular phase, agonist triggering, 5 days stop, and you start again from the second stimulation, not in all patients, but in general, you will have more X from second stimulation. This is a crucial point. And I conclude to tell you something. This is an intriguing study that has been performed by the group of genera. So patient advanced maternal age, patients 40, 41 years of age. So we are talking about group 4 Poseidon, patient with a low ovarian reserve, but still acceptable, that can be still stimulated. They were not randomized. This is a general experience. They were given the possibility, only patient that had from 0 to 3 blastocysts, they were given 2 possibilities. One possibility is to continue with the second stimulation in those Stim, double stimulation. Other patient that refused this option were had the possibility to have a second stimulation when they finished the blastocyst, having a second stimulation in the follicular phase at the same price of those Stim, because usually in those Stim, it is proposed a second round cheaper, no? So they say, you have 3 blastocysts, you can continue in a second round stimulation accumulating, or you can use your blastocyst, and if you will not have pregnancy, you can have a second stimulation. So 2 different approach, okay? And let me tell you what happened. So this is the group, this is if you have looked to the red, is the dropout. This is conventional, 2 follicular phase stimulation. This is dual Stim. Vast majority of a patient that decided to transfer available blastocyst and move to the second stimulation in case of failure dropped out. 80% dropped out, left the program. Obviously, patient that accepted dual Stim, all of them completed the 2 stimulations because the commitment was there to have more embryos and to complete 2 stimulation. Okay, so the dropout is very important aspect. And in terms of pregnancy, live birth rate, the live birth rate was significantly increased by, it is reported, if I remember well, is 12% against 24%. 24% live birth rate in dual Stim group and 12% in 2 conventional. So it doesn't make miracles. Anyway, the live birth rate is low, but moving from 12 to 23, 24% in this category of patient is very important. And if you perform a cost analysis, you can see something that is very important. The cost per patient is higher because patient doing dual Stim obviously spend probably, I cannot say double, but they spend 70% more, obviously. The cost per cycle, per treatment is higher. But if you consider that they moved from 12, 24 to 24% pregnancy, if you consider a very important which is endpoint, which is the total cost per pregnancy, the total cost per pregnancy was significantly lower in the dual Stim approach. So it depends on the setting of the organization, public, private, whatever. So who pays? So it's very difficult to do, I can say, a cost-effective analysis. But what is important, in my opinion, is that with the dual Stim approach, the cost is higher, but the chance to be pregnant is the double. And what is important, the dropout rate is proximum to 0. So this is just to give an idea of possible application of dual Stim. So these are the conclusion. And I think that we need more studies for testing dual Stim in group 3, 4 Poseidon, but I think that these are the categories of patient that can benefit from this approach. So thank you very much for your attention.